Listen, I want you to picture something. A Monday morning in January of 2026, a living room in a craftsman house in Cincinnati, Ohio. Her name is Helen. She is 73 years old. She spent 31 years as a registered nurse at a regional hospital system. She retired in 2019 and began to enjoy her well-earned retirement. She has been enrolled in a UnitedHealthcare Medicare Advantage PPO plan for 4 years. This plan has provided her with coverage for quite some time now. The plan has served her well throughout those 4 years. Her primary care physician, Dr. Alvarez, has been her doctor for 11 years. The plan covered him, which made things very convenient for her. Her cardiologist, who has been managing her atrial fibrillation since 2022, was in network. The plan covered him as well, ensuring her heart health was managed. Helen found out in October of 2025 from a one-paragraph notice buried inside the annual Notice of Change letter that the hospital system where both Dr. Alvarez and her cardiologist practice, TriHealth, would be exiting the UnitedHealthcare Medicare Advantage network effective January 1st of 2026. Helen had been a registered nurse. She read the notice carefully. She understood immediately what it meant for her healthcare access. Dr. Alvarez was no longer in her plan. Her cardiologist was no longer in her plan, creating a difficult situation. To continue seeing both of them, she would need to either pay out of pocket, which was not financially sustainable given the frequency of her cardiologist visits, or leave the UnitedHealthcare Medicare Advantage plan to find a better option. TriHealth is one of 15 major health systems that dropped Medicare Advantage plans in 2026 as part of a broader industry-wide pullback. UnitedHealthcare and Humana alone were projecting forced disenrollments of approximately 600,000 and 500,000 members respectively, a significant number of people. Aetna discontinued approximately 90 Medicare Advantage plans across 34 states. UCare, a Minnesota-based nonprofit, exited the Medicare Advantage market entirely, affecting approximately 158,000 enrollees who now need new plans. In Vermont, the state's individual Medicare Advantage market experienced a near total collapse, with more than 51,600 enrollees losing coverage in the state of Vermont. According to research published in the American Journal of Managed Care, the forced disenrollment rate for Medicare Advantage in 2026 was projected to reach 10%, affecting approximately 2.9 million enrollees, compared to less than 1% between 2018 and 2024. Helen is not alone. Helen is one of 2.9 million. And Helen, unlike many of the 2.9 million, is thinking clearly about what the switch means. She called a Medicare insurance specialist in November to discuss her options. She was told she could switch from Medicare Advantage to Original Medicare plus a Medigap supplement during the annual enrollment period that ran through December 7th, 2025. She enrolled in Original Medicare Part A and Part B, and selected a Medigap Plan G policy through a regional insurer. The Medigap Plan G premium in Ohio for a 73-year-old woman is approximately $187 per month. Helen's Medigap Plan G premium is $187 per month. Her Medicare Part B premium is $202.90 per month. The switch to Original Medicare plus Medigap costs Helen $113 more per month, $1,356 more per year in premium. She has continuous access to Dr. Alvarez and her cardiologist because Original Medicare pays any physician who accepts Medicare assignment, regardless of network. The switch was the right medical decision for her specific health needs. It was possibly the right financial decision when accounting for the out-of-network costs she would have incurred in the MA plan. But Helen made the switch without asking one very important question. She made the switch without asking whether the way she was funding the additional $1,356 per year was the most tax-efficient method available, and without asking whether the switch itself opened a planning window that she could use to optimize her retirement income picture before it closed. That is the dimension nobody in the Medicare switching conversation ever discusses. This is the tax-smart way to make the switch and protect your income. The income sourcing strategy that funds the premium differential at the lowest possible after-tax cost. The IR-MAA interaction that may have changed when the switch moved her from the MA plan's income threshold structure to Original Medicare's direct IR-MAA calculation. And the Roth conversion window that the premium increase may have inadvertently opened. Tell me which income source you are using to fund any premium increase, and whether you modeled the after-tax cost difference before making that choice. That is what we are covering today. Smash the like button right now. The Medicare Advantage market in 2026 represents the largest single-year network disruption in history. Approximately 2.9 million beneficiaries are navigating the switch from Medicare Advantage to either a different MA plan or Original Medicare plus a Medigap supplement Every like on this video puts this analysis in front of one more beneficiary who made the switch for the right medical reasons and is now paying the premium differential. Almost none of them have had a conversation about the tax-smart way to fund the premium differential as part of a coordinated retirement income strategy. Let me start with the enrollment window mechanics, because the legal window for making the Medicare Advantage to Medigap switch is different from what most beneficiaries assume. And getting the timing wrong affects both the coverage continuity and the guaranteed issue rights for Medigap enrollment. During the AEP, beneficiaries can switch from a Medicare Advantage plan to Original Medicare, from Original Medicare to Medicare Advantage, or between different Medicare Advantage plans. A switch made during the AEP takes effect January 1st of the following year. The Medicare Advantage open enrollment period runs from January 1st through March 31st each year. During the OEP, beneficiaries who are already enrolled in a Medicare Advantage plan can switch to a different MA plan or return to Original Medicare. A switch made during the OEP takes effect the first day of the month following the election. For Helen, who made her switch during the 2025 AEP, effective January 1st of 2026, the timing was optimal. For beneficiaries who missed the AEP and are still in an MA plan that dropped their doctor in 2026, the OEP through March 31st is still available. A switch made in February during the OEP takes effect March 1st. When a beneficiary switches from Medicare Advantage to Original Medicare, they generally want to enroll in a Medigap supplement to cover the out-of-pocket costs that Original Medicare leaves exposed. Medigap policies have guaranteed issue rights, meaning the insurer must accept the applicant regardless of health status during specific windows. Outside those windows, Medigap applications are subject to medical underwriting, and applicants with pre-existing conditions can be denied coverage or charged significantly higher premiums. The guaranteed issue window for Medigap enrollment when switching from MA to Original Medicare is triggered when the MA plan is being discontinued or the beneficiary is moving out of the plan's service area. For Helen, whose plan continued but whose preferred doctors left the network, the guaranteed issue right depends on whether her specific situation triggers the trial right provision, and then switches back to Original Medicare within the first year. For beneficiaries like Helen, who have been in the MA plan for several years, the guaranteed issue trigger is more limited. Most states require Medigap insurers to accept all applicants during specific qualifying windows, but the exact trigger varies by state. Ohio has specific guaranteed issue protections that go beyond federal minimums and provide annual Medigap birthday rules in some circumstances, and can be financially catastrophic for a 73-year-old with atrial fibrillation and frequent cardiology visits. Verify the guaranteed issue eligibility before making the switch. Now let me address the tax-smart premium funding question. That $3,790.80 per year is a real additional cash expense that Helen needs to fund from her retirement income. Option 1. Fund the premium increase from traditional IRA distributions. Additionally, if the $4,963.80 IRA distribution pushes Helen's 2026 Magi above an IRMA tier threshold, Option 2. Fund the premium increase from Roth IRA distributions. The Roth funding option saves Helen $1,173 per year in combined federal and state income tax, while also protecting her 2028 IRMAA tier status. It contributes to the IRMAAM-AGI calculation for the year 2 years forward. A Roth IRA distribution does not appear in adjusted gross income. It does not enter the provisional income formula. It does not enter the IRMAAM-AGI calculation. Option 3. Fund the premium increase using a qualified charitable distribution offset strategy. If Helen has charitable giving intentions and is over age 70 and a half, a qualified charitable distribution from the IRA under Section 408D8 satisfies a portion of her required minimum distribution without the distribution entering adjusted gross income. If Helen uses a QCD to fund $3,790.80 of charitable giving that she was going to do from cash anyway, she frees up $3,790.80 of after-tax cash that was previously earmarked for charitable donations. That freed cash funds the premium differential. The effective result? The premium increase is funded without any additional IRA distribution, without any MAGI increase, and without any IRMAA consequence, because the QCD simply redirects IRA money to charity without entering the income calculation, freeing existing cash to cover the premium. Tell me in the comments right now. Tell me whether your Medicare Advantage plan dropped a doctor or exited your area in 2026. Tell me whether you switched to Original Medicare plus Medigap or to a different MA plan. Tell me your state. Drop the details in the comments. I read every single one. We model the tax-smart funding strategy together. Before the Roth conversion window analysis, let me quantify the full scale of the 2026 Medicare Advantage disruption with precise figures from the research, because understanding the magnitude explains why this specific planning question affects millions of people simultaneously in 2026. According to a study published in the American Journal of Managed Care, analyzing over 192 million enrollee years, approximately 2.9 million Medicare Advantage enrollees faced coverage termination in 2026. Aetna discontinued approximately 90 MA plans across 34 states, primarily PPOs. UCare of Minnesota exited the MA market entirely, affecting approximately 158,000 enrollees. Vermont's individual MA market experienced a near total collapse, with more than 51,600 enrollees losing coverage. 15 major hospital and health systems dropped specific MAA contracts in January of 2026 alone, including Mayo Clinic, Mass General Brigham, TriHealth in Cincinnati, Providence Clinical Network in California, and others. The Newsweek report listing these exits described it as, in one Medicare specialist's words, bait and switch at scale. PPO enrollees represented approximately 49% of disenrolled individuals. Rural beneficiaries represented 28% of the disenrolled. For the 2.9 million beneficiaries facing this disruption simultaneously, the planning question of how to make the switch tax efficiently is not an academic exercise. It is the most consequential Medicare cost decision these beneficiaries will make in 2026. And for most of them, it is being made without any modeling of the income sourcing dimension. Now let me address the Roth conversion window analysis, because the premium increase from switching to Medigap creates a specific planning interaction. The switch from a Medicare Advantage plan to Original Medicare plus Medigap increases Helen's Medicare premium from $74 per month to $389.90 per month, a $315.90 monthly increase. But there is a second financial dimension to this switch that runs in the opposite direction. Under a Medicare Advantage plan, Helen's out-of-pocket maximum in 2025 was $10,000 per year for in-network care. Texas Medigap premiums for a 73-year-old average approximately $165 to $190 per month, lower than both Ohio and California due to Texas's generally lower healthcare cost environment. This protects against the risk of selecting an initially attractive plan that later becomes uncompetitive in premium pricing relative to alternatives in the market. Save this video to your private library right now. Hit the save icon. Add it to the retirement survival playlist. The medical and insurance dimensions of those decisions are being covered widely. The tax dimension of those decisions is not. Fund the premium from the right income source. Preserve the Roth balance for the right use. Protect the IRMAA tier by keeping the premium funding out of MAGI. Under Original Medicare plus Medigap Plan G, Helen's out-of-pocket exposure is structurally different. Medigap Plan G covers all Medicare-approved costs after the Part B deductible of $283 per year. Helen's annual out-of-pocket exposure under Plan G is capped at the Part B deductible of $283. Compared to the $10,000 out-of-pocket maximum under the MA plan, the switch to Medigap eliminates approximately $9,717 of potential annual out-of-pocket exposure. This is the predictability gain from the switch. Helen's total healthcare spending under Medigap is nearly fixed at the premium cost plus the Part B deductible, regardless of how frequently she uses healthcare services. The predictable total annual Medicare cost under Original Medicare plus Plan G is approximately $4,970.80, being 12 times $389.90 plus $283. The previously unpredictable MA annual cost could have ranged from near zero to $10,000, depending on service utilization. For a 73-year-old with atrial fibrillation, the predictability premium is worth paying. Let me also model the Medicare Savings Account alternative for completeness. A Medicare Medical Savings Account plan, or MSA, is a type of Medicare Advantage plan that pairs a high-deductible health plan with a savings account funded by Medicare. The MSA receives an annual contribution from Medicare, which in 2026 averages approximately $2,100 to $3,600, depending on the plan and location. The beneficiary uses the account to pay qualified medical expenses before the deductible. The MSA contribution is tax-free and the growth is tax-free when used for qualified medical expenses. The MSA is worth evaluating for generally healthy beneficiaries who have sufficient liquid savings to cover the high deductible in a high utilization year. The MSA eliminates the Medigap premium while providing the tax-free account funded by Medicare. However, the MSA is not combined with standard supplemental coverage, and in a high utilization year, such as a year with a hospitalization, the beneficiary faces the full high deductible before Medicare covers services. For Helen, with atrial fibrillation and regular cardiology visits, the MSA is not the right choice because the annual utilization makes the high deductible design financially unfavorable. For a healthier beneficiary making the switch from a dropped MAA plan, the MSA warrants evaluation as a zero premium alternative with the tax-advantaged account funded by Medicare. The Roth conversion window interaction comes from this predictability. Helen's annual Medicare cost under Medigap is fixed and known. She can model her annual MAGI with precision. She knows her Medigap premium, her Part B premium, and her predictable total Medicare cost. She can plan Roth conversions sized to keep her annual MAGI below the IRMA tier thresholds with confidence, because the Medicare cost variable is predictable rather than dependent on service utilization. Under the MA plan, a high utilization year could have generated significant out-of-pocket spending, making Roth conversion funding unpredictable. Under Medigap, the fixed premium structure allows Helen to plan the conversion amount with precision and confidence. The switch to Medigap indirectly improves the precision of her Roth conversion planning for the remaining years before her RMDs reach their peak. Now let me give you the geographic dimension. In Ohio, where Helen lives, the Medigap market is regulated under Ohio Revised Code, and insurers are required to provide guaranteed issue access. Ohio also provides birthday rule protections that allow Medigap policyholders to switch plans annually with guaranteed issue rights. The Ohio Medigap Plan G premium for Helen's age of 73 is approximately $187 per month from regional insurers, compared to the national average. In California is one of the few states that guarantees Medigap enrollment rights on an annual basis regardless of health status, under California's open enrollment rules for Medigap policies. The California Medigap market offers more consistent access to Plan G for older enrollees than most other states. California Medigap premiums for a 73-year-old average approximately $215 to $260 per month, depending on the insurer, higher than Ohio due to higher healthcare costs. In Texas, Medigap is subject to federal guaranteed issue rules without the additional state protections that Ohio or California provide. Texas does not have a birthday rule. Texas Medigap guaranteed issue rights are more limited than Ohio, making the underwriting risk for a 73-year-old with atrial fibrillation more significant. Texas Medigap premiums for a 73-year-old average approximately $165 to $190 per month, lower than both Ohio and California due to Texas's generally lower healthcare cost environment. In Florida, similar to Texas, Medigap guaranteed issue rights are governed primarily by federal rules without additional state birthday rule protections. Florida Medigap premiums for a 73-year-old average approximately $175 to $210 per month, varying significantly by county due to Florida's geographically diverse healthcare market. Now let me give you the 5-step action sequence. Step 1. Confirm the enrollment window. The Medicare Advantage open enrollment period runs through March 31st. If you are still in a Medicare Advantage plan that dropped your doctor and you have not yet made the switch, you have until March 31st to switch to Original Medicare or to a different MA plan, with the change taking effect on the first day of the following month. Step 2. Before making the switch to Original Medicare, confirm your Medigap guaranteed issue eligibility with your state insurance department or a licensed Medicare counselor. Do not assume that switching from MA to Original Medicare automatically triggers guaranteed issue rights. Verify the specific qualifying event and the specific window in your state before making the coverage election. Step 3. Identify the after-tax cost of the premium differential between your old MA plan and the new Medigap plan. Calculate the gross IRA distribution required, accounting for your marginal federal and state income tax rates. Compare this to the face value Roth distribution required to generate the same cash. The difference between the two numbers is the annual tax savings from funding the premium from Roth rather than from the traditional IRA. Step 4. Evaluate whether the QCD strategy can offset the premium increase by redirecting charitable giving through the IRA without the distribution entering MAGI. If you have annual charitable giving intentions and are over age 70 and a half, execute the QCD in an amount equal to the annual premium differential before year end to free the equivalent cash for the premium cost that allow Medigap policyholders to switch between plans of equal or lesser benefit once per year within a specified window after the policy anniversary date. If you are in a birthday rule state, you can start with the plan that is most accessible and switch to a lower premium equivalent plan in a future year. This protects against the risk of selecting an initially attractive plan that later becomes uncompetitive in premium pricing relative to alternatives in the market. Step 6. Model the Medigap premium cost as a fixed annual expense in your MAGI projection for IRMA planning purposes. The predictable Medigap premium allows precise MAGI modeling. Use this predictability to size annual Roth conversions to keep MAGI below the IRMA tier boundaries. Save this video to your private library right now. Hit the save icon. Add it to the retirement survival playlist. Because Helen made the right medical decision by switching to Original Medicare and Medigap to preserve access to Dr. Alvarez and her cardiologist. She did not ask the tax question. She is funding the $3,790.80 annual premium differential from her traditional IRA, paying $1,173 in additional annual combined federal and Ohio state income tax that she did not need to pay if the Roth funding strategy is implemented. The medical decision was correct. The income sourcing decision was the default. The default costs $1,173 per year. The tax-smart alternative is available. Subscribe if you have not. Flip the bell. Comment with your Medicare switch situation, your state, and whether you modeled the tax-smart funding strategy. I read everything. The Medicare Advantage market disruption in 2026 is forcing millions of beneficiaries to make decisions about coverage that they did not plan for. The medical and insurance dimensions of those decisions are being covered widely. The tax dimension of those decisions is not. Fund the premium from the right income source. Preserve the Roth balance for the right use. Protect the IRMAA tier by keeping the premium funding out of MAGI. The switch was forced by the market. The tax optimization is available by choice. I will see you in the next one. Stay strategic. Stay covered. The network that dropped your doctor created a planning window. Use it. A qualified charitable distribution from the IRA under Section 408D8 satisfies a portion of her required minimum distribution without the distribution entering adjusted gross income. Her total monthly Medicare cost under the discontinued UnitedHealthcare MA plan was $74. The monthly premium increase is $315.90. The annual premium increase is $3,790.80. Now, the critical difference between AEP and OEP switches as they relate to Medigap guaranteed issue rights. Helen, as a retired nurse, researched this carefully. She confirmed her guaranteed issue eligibility before switching. Other beneficiaries in her situation may not know to ask. The consequences of switching to Original Medicare without confirming Medigap guaranteed issue eligibility and then being denied Medigap coverage due to medical underwriting are severe. Without a Medigap supplement, the 20% coinsurance under Original Medicare Part B is uncapped. Helen's Medigap Plan G premium is $187 per month. Her Medicare Part B premium is $202.90 per month. Her total monthly Medicare cost under Original Medicare plus Medigap is $389.90. The question is which income source she uses to fund it, because different income sources carry different effective tax costs. A traditional IRA distribution is taxable ordinary income. It enters Helen's adjusted gross income. It contributes to the provisional income formula under Section 86, potentially increasing the taxable portion of her Social Security. To generate $3,790.80 of after-tax cash from the traditional IRA at her 22% federal marginal bracket, plus Ohio state income tax of approximately 3.5%, Helen must withdraw approximately $4,963.80 from the IRA, paying $1,173 in combined federal and state income tax on the withdrawal. The effective cost of the premium differential is $4,963.80 of IRA withdrawn, not $3,790.80 of premium paid. The 2-year look-back produces elevated Medicare premiums in 2028. The traditional IRA funding option converts a $3,790.80 premium expense into a $4,963.80 gross expense, with potential downstream IRMAA consequences 2 years later. Every dollar of Roth distribution used to fund the premium differential reaches Helen's checking account at face value, with zero additional tax cost. To generate $3,790.80 of cash to fund the premium differential from the Roth, Helen distributes exactly $3,790.80 from the Roth. No gross-up required, no additional income tax, no IRMAA downstream consequence. The effective cost of the premium differential from the Roth is $3,790.80 of Roth balance distributed, period. This is a continuation of our forensic examination into Medicare switches. Remember to stay strategic and informed about your financial health. Protecting your retirement income is our top priority today. The network disruption is real, but your plan can be optimized. Thank you for following along with this detailed tax analysis. Your comments and feedback help us reach more people like Helen. We are committed to helping you navigate these complex changes. Every financial decision counts when it comes to your Medicare coverage. Stay tuned for more updates on the 2026 Medicare Advantage market during the annual enrollment period that ran through December 7th.